All right, so I guess we'll go ahead and get started. So today's lecture seminar is kind of just a little different perspective on the opioid epidemic than we've seen through our last lecture and that we'll see for the rest of the lectures. And the opioid epidemic is obviously a very multifaceted issue. So today we're going to get kind of the perspectives from law enforcement and from somebody who worked in law enforcement for a long time in Pennsylvania. So today we have Stephen Forzato with us, who is the director of the Center for Addiction and Recovery Education at St. Joe's. And I'll turn it over to Stephen.
Thank you, Joseph. Raise your hands. How many of you have heard of CARE at St. Joe's? Oh, I got to work on our marketing. Couple hands. All right. Good. So the Center for Addiction and Recovery Education, I think you know this, but in most universities and colleges, there are centers and institutes that address sometimes health issues, equity issues, social issues, and so forth. And so St. Joe's has always been involved with collegiate recovery programs. In fact, we're really well known in our area for having really robust collegiate recovery programs. But St. Joe's decided to have a center that is solely focused on addiction. Addictions of many kinds, like gambling and so forth as well. We're going to get into that. But substance use disorder is clearly an addiction that has impacted America in a terrible way over the last 5, 10, 15 years. When I was young, if somebody was using drugs, let's say cocaine or methamphetamine or marijuana to a heavy extent, or prescription pills, and they were psychoactive, right? They were opioids or they were other, barbiturates and so forth that would give people some pleasure. 20, 30 years ago, if you were using, the harm might be you would disappoint your family, right? Broken relationships. You might fail out of school or really struggle in school, or you could lose your job or get a DUI. That's always been an issue, right? And so, but nowadays, what is the harm, additional harms? Are there additional harms that are different today than before? And the answer is yes. And obviously overdose is one of those differences. Whereas there's 107,000 on average overdoses, 107,000 overdoses of Americans every year. Back in the 1960s, 1970s, even into the 1980s, nationally it was just in the thousands. Wow. And so things are different now. Your generation, America today, historically, we are at a crisis point. It is truly a public health crisis, including all of the other harms that addiction can cause. Broken relationships and sort of lack of employment and so forth. And clearly jail, right? Because illicit drugs are illegal. So anyway, this center of ours addresses addiction, but there's a lot of hope in this and recovery. People can and do recover from substance use disorder, from alcohol use disorder, opioid use disorder, all of these disorders, that psychiatrists put into DSM-5, substance use disorder is a real deal medical condition. I even believe it to be a disease. And so, bottom line is St. Joe's is addressing addiction in one way, in a big way, through the CARE Center.
Yeah, that's great. Mm-hmm. I also forgot to add, if you have any questions, just raise your hand throughout because we can see the Zoom here, rather than waiting for the end. We'll do that as well, but if you have any questions throughout, feel free to jump in.
Great. So my background, Joe, is in law enforcement. So why did St. Joe's pick me to run a center? Aren't there plenty of PhDs or medical folks that could run a center that addresses this disease? And the answer is absolutely. I was kind of shocked I got the job. But for 33 years, I served in law enforcement. 31 in Montgomery County, which is our campus is in Montgomery County on the lower Marion side. And I both participated in undercover work, street work having to do with drug dealing, drug trafficking, and I posed as a substance user. My first undercover assignment, I posed as a heroin user to buy heroin from a dealer in Norristown. And before I went to this little hole-in-the-wall restaurant in Norristown where it was being sold, I used to prick the back of my hands to make track marks. I wore a long flannel jacket, a long sleeve flannel jacket, because I didn't feel like doing track marks up and down my arms. And I just sort of pricked the back of my hands, and I'd walk in there. I learned how to look like I was under the influence, and I went in as a user, not a dealer, not somebody buying large quantities. I was young, they weren't going to put me in with cartels. They wanted to try me out with this simple little assignment. Right. It took me 3 weeks to buy one bag. I used to go in almost every day, and I would nod off on the table at this restaurant like all of the others that were in this restaurant that were under the influence. And after 3 weeks, they finally sold to me. They sold to people at the tables that sold to me, but I wanted to get it right from the main guy. And so that was my first heroin buy. I was 22 years old. My last heroin buy, I was 52 years old. You might think, well, why did you do that? I mean, at that point, I was a lieutenant.
Right.
And I had 12 detectives. I had 400 cops that were in my task force. I could have picked any one of them. Well, I wanted to prove my young detectives I still had it in me. So I went in. It was in 2015, and all I had to do was call a phone number. Right, the guy just advertised his phone number. Whereas in the 1990s, when I started, you had to spend 3 weeks convincing your dealer that you were for real.
Yeah.
This time in 2015, 2016, I just called a phone number. And I still have his number on my phone. And I called him up. He was called the Kid. He drove a silver Acura, and he carried a gun, and he sold bundles of heroin, right? Bundles are about 10 to 14 bags. So $70 in that case got me a bundle, got me 10 bags. So I ordered up 2 bundles of heroin. Boom, he met me at actually a hotel in Norristown, kind of a tough hotel in Norristown, and met me there and sold me 2 bundles of heroin, and then my team took them off. So what was the difference? The supply was low in 1990. The supply is great in the 2020s, 2023, this year. There's so much supply, and so it's different now, and so many more users. So why do you think opioids all of a sudden, opioids are so popular? What do you think, Joe?
I mean, popular just within.
It's a popular drug. Back in the 90s and the 80s, very small clique of people used heroin.
Yeah,
and
I mean, I guess it would have to have something to do with the prevalence of opioids being prescribed for painkillers.
Exactly. So you future prescribers, right? Reverse the trend. It's getting reversed. Medical professionals, doctors are prescribing less opioids. It's prescribing a lot of stimulants, but the trend is not to prescribe as many opioids as they did in the 90s and early 2000s. And so, but you got addicted to the pills. If you lost your life, you lost your insurance, right? Let's say you lost your job, you lose your insurance, and you're so addicted to these pills, you don't have the money to go to the doctor anymore. There's now no copay, right? You got to pay the full boat. And then you got to then pay the full boat at the pharmacy, which is not cheap.
Yeah.
So rather than $150 to $200, maybe a month, $300 a month, now you're going to the street to get the same high from either pills you get on the street or the heroin, which is $3 to $5 a bag. So things are different now. And the other reason why there's such a popularity with drugs like heroin and fentanyl is, you can raise your hand. How many of you don't like needles? You don't like to go to the doctor and get a shot. Like, I'm raising my hand. I don't like that stuff. Most of us are needle adverse. In the 1960s, if we were part of the hippie movement, I think it was 69, Woodstock. I hope you guys see some of those YouTube videos. It's pretty cool. There's a free love type of thing. Anyway, in the 1960s, the heroin quality was so low, 5-10% pure, that if you snorted it, right, if you didn't like syringes, shooting drugs in your veins, if you didn't like that, and you snorted heroin in the 1960s, it wouldn't make you very high, right? You wouldn't have a profound effect because it was so impure, right? 95% cut, 5% active heroin. What do you think the heroin, what if in chat you could put this in there? What do you think the purity of heroin is today? Let's just go with southeastern PA, Philadelphia. It was 5% in 1960s. What do you think the purity of heroin is today? Anybody? Come on, somebody. Type it in there. Just throw it out there.
65%, 95%.
So whoever said
20%.
95%, I want to give him or her a prize. Yeah, it's in the 90s in the Philadelphia market. Yeah, sometimes you'll get a dealer that's steps on it, put some adulterant and cut into it, or you could get a bag with 50%. Let's say you're not going to get 5%. A drug dealer would go out of business. But with 95% heroin, people that start out not wanting to shoot it, but snort it, they get a high impact, a high purity level dosage, and it does have a profound effect. Unfortunately, over the weeks of using it by snorting, most people overcome that needle adversity, and they literally learn how to draw heroin and water into a syringe and inject it, because then the high is even greater. Does that make sense?
Right, yeah.
So, all right. I hope you're thinking about questions, because we're just going to talk.
Yeah. Sure. So I guess you kind of covered how things have changed throughout your career. Is there any, milestone experience that you had when you kind of saw this change?
Yeah. So I witnessed with my own eyes both non-fatal and fatal overdoses. I'll talk about Earl, all right? And I changed names because I like anonymity for people. Right. I don't want to stigmatize them. But Earl would get a check every month. He was about 35 years old. Every month, a check would be sent to him from the federal government, Social Security disability check. And my informant, and by the way, he would take that money, he would take that check, go to a check cashing place in Norristown, get his cash with it, he'd have to pay a fee, but get that cash, and off to Philadelphia he went. His girlfriend would drive him down to Kensington, and they would cop a couple bundles with that money. He'd bring it back to Norristown and sell it, but he used it, right? So he was a user seller. Right. He sold to finance his own habit. So the informant in the case, and this is a long time ago, so I could talk a little more detail, right? It's like 25 years ago. But this is a changing moment in me. The informant was the post office, the delivery guy. And he heard from the neighbors, this guy's trouble. Every time he gets the check, the Social Security check, I think it was early in the month, he would cash it, go down and he'd come back really, really high, And so the postman was my confidential source. So the next month, he called me, he says, okay, we got these Social Security checks. Yeah. I'm going to deliver it to Earl. And so I just sat outside and watched. We had a couple of us there and watched them get the check. And like clockwork, where did Earl go? He went to the check cashing place with his girlfriend, and then she drove him down to Philly. We drove down and followed him down. He could have gone anywhere, but he went to Kensington. So we had to watch, make sure he didn't see us. Right. But I could tell you both Earl and his girlfriend were both living with a substance use disorder. So they weren't even looking in the mirror. They were singularly focused on getting to their favorite dealer. So I didn't have to worry about it, but we would switch cars that were following all that. We get down, we watch Earl get out of the car, walk up to a couple people that were on the street, and they knew him. He was like a monthly customer. Boom, and he had the money. We saw the exchange. And then Earl jumped in the passenger seat. She started to drive him back towards Norristown. But while she's in the neighborhood, I see Earl's head down. And so what Earl was doing was he couldn't wait. So addiction takes over the brain, And there's an immediacy to needing to use this. And we'll talk maybe a little bit about brain science of why that is. But yeah, he took a spoon out, and I couldn't see it, but his head was down.
Right.
But what he did is he took out his spoon, put some water through a bag, or he actually threw 2 bags of heroin because he had a heavy habit, tolerance built up. And then he cooked it up with a lighter, and then he drew it into a syringe in a moving car. He was very good, right? And he injected himself.
Yeah.
And all of a sudden, after he injected himself, I see Earl's head. He nodded off, right? And then he slid over to his girlfriend and was laying on his girlfriend while she's driving. Ladies and gentlemen, she drove right by Temple Hospital. He looked like he was dead to me.
Yeah.
You know, and she started to panic. She turned the car around. She went back into the neighborhood, got out, and told the dealers, my boyfriend is overdosing. I could hear her, right? What am I going to do? And they just yelled at her and said, get out of here. They don't want that. They don't want police there. They don't want the ambulance there. So now she's forced to try to deal with this on her own. Back then, they didn't have Narcan available to people. It was in the ambulances, but not the people. And she panicked. Again, she drove right by Temple Hospital, where she could have stopped. Nobody was stopping in these days. The Good Samaritan Act, had she stopped and let's say Earl's dead, she might have gotten charged, you know? Like the Good Samaritan Act that we have in Pennsylvania gives immunity for people like her trying to save someone's life.
Yeah.
That Good Samaritan Act is good on campus. You know, you come back to your dorm and your roommate comes back, you know, just reeking of alcohol, passes out, begins to vomit. There's no reason why you shouldn't call for public safety and 911 because the law protects you and, by the way, protects your roommate. You know, we don't want to discourage people reporting overdoses or excessive drinking or medical conditions. So I know, not available back then. So as she's driving up, of course I wanted to wait till Earl got home because that's where he stashed the heroin, and then maybe watch some of the customers come up and buy from him and do a long-term investigation. But Earl looked out and she looked panicked.
Yeah.
So coming off the Schuylkill Expressway at Conshohocken, I just had the car pulled over. Called patrol. We were all undercover. But called patrol, we pulled him over. I walked up to the car, and Earl had the syringe laying on his lap, blood coming out of the injection site, and I counted his respirations. Opioids affect respirations. People ask me, well, what causes death with heroin and fentanyl and opioid pain medication when one takes more than they need for medical necessity? Well, it affects the respiration first, right? Yeah. And so Earl, I looked, and I called the ambulance, waiting for the ambulance to come. By the way, I didn't have Narcan at the time. It was not available to police. It was in the ambulance. So I called for the ambulance, and I counted his respirations. He inhaled 4 times a minute. That's it. Every 15 seconds, he took a deep breath, and it sounded like it was a death gurgle coming out of him.
Yeah.
So there he is. He's got blood coming down the injection site, the syringe on his lap. Inhale just every 10, 15 seconds.
Oh.
And then the ambulance arrived. And I helped them. They grabbed Earl. They put him in the back of the ambulance, and they found the vein, right, to do a port. They were able to do a port, and into Earl they pumped in naloxone. And I watched Earl wake up at about 2 or 3 minutes, try to fight a little bit. And then I sat in the back of the ambulance till they went to the hospital in Norristown, Montgomery Hospital it was called. And I was in the ER with Earl, and I started to talk about Earl to the doctors and the nurses there. And they said, oh, that's Earl. He's here every month. Every month. So what happens to Earl every month is as he runs out of money, he can't get heroin. He starts to detox and the withdrawal symptoms towards the end of the month. Then when he goes to buy, because he's got a check now and got money, his tolerance level lowers.
Right.
So Earl injected 2 or 3 bags when he first bought it. thinking, I can handle that. Well, you can't, because the tolerance level depletes. That's why people that go to jail for, let's say, a week or 30 days or 6 months or 2 years,
Right.
when they come out and they start using the same quantity, end up overdosing because their tolerance levels have lowered and their body's like, man, you put too much in you. So that's what happened to Earl. He survived. I arrested him, but it was the first time, so that was alarming to me, just to see all of that.
Yeah.
Unfortunately, you're going to see it all the time. Particularly if you work, well, you work anywhere. I don't care what, suburban America or city America, even rural America, you're going to see overdoses. What they didn't have back then, the doctors, the nurses were not educated in connecting people to treatment. That's a great place. I mean, if every month Earl ended up at this hospital in Norristown, wouldn't that be a great time every month to build a relationship with Earl, knowing he's going to come back, and talk to him about getting treatment for this medical condition? Oh, the hospitals weren't doing it. They had as much stigma as cops did back then. They got tired of Earl because they had other things happen, gunshot wounds, car crashes. Earl, every month, like clockwork, would come in. But that was a missed opportunity. By the way, for 20, 30, 40 years, emergency rooms missed the opportunities to connect people to treatment.
Wow.
Yeah.
Yeah. Do you want to expand a little bit on, I guess, stigma? What is stigma and how that kind of has
Absolutely.
affected law enforcement?
So, stigma. All of us have internal bias, right? Some of us have worse than others, right?
Yeah.
But so all of us have lived experience. So I'll tell you, I'm 58 years old. So I have 58 years of lived experience. Let's talk about drugs and alcohol. Over those 58 years, I've seen things that have impacted my opinion about people that drink way too much. Listen, I was in law enforcement. Car crashes where the person reeking of alcohol walks away from their car, not a scratch, but they slam into a minivan with a family full of kids. Like, imagine being a police officer and seeing that not once, twice, but 5, 10 times early in your career. You're going to think, look, these people that are drinking too much, they don't have a medical condition, they have a crime problem, and I just want to lock them up, right? What happens when you lock up somebody that's struggling with alcohol? When they get out of jail, what are they going to do?
Yeah, go drink.
Yeah, they're going to go drink, right? I mean, prison oftentimes is traumatic.
Right.
Man, you need a good stiff drink to get through what you serve.
Yeah.
So the idea of not having a good positive engagement is a missed opportunity. So anyway, I forget your question, but
Just about stigma in
yeah,
general.
yeah. So hey, I had every right to my stigma. Like I was in my 20s, early in my career, and it's my lived experience. It takes education to understand that not every person who has an alcohol issue or a drug issue is killing people, hurting children. Not everyone is. We have to sort of understand that the worst that we see doesn't give you the whole view of addiction. There are some people who are responsible. They'll get a cab or Uber, but yet they suffer because they can't stop using. They try. One thing about substance use disorder, in the DSM-5 manual, one way you can tell that you're struggling with a substance that you can't stop is you try to stop, and man, you just can't beat it. You try to reduce. Instead of drinking 12 beers a day, you try to drink 2. And that works for a day or two, and then you're back to 12 or a bottle of wine. Same with heroin. You try to cut back from 30 bags a day, try to cut back to 5 or 10. And you can do it for one day, but all of a sudden, boom, you can't stop. So anyway, this substance use disorder thing is it's tricky. And so when we have stigma, and by the way, medical folks have it, right? Imagine being an ER doctor in Philadelphia, right? That's easy to imagine. You see all the gunshots that are going on. Yeah. It's like being in a war down there. So you get a call. They're bringing in an 18-year-old male, 3 gunshot wounds. Police are driving them in. They just scooped them out from the scene, and they're driving them in to your hospital. And you're an ER doctor, right? And so now you're preparing for a young person you don't want to see die. You don't want to see anybody die, but this person, you want to make sure that you do your best to save them. And all of a sudden, you got 3 overdoses coming in, right? So you look at the 3 overdoses coming in, and you start to judge, right? Whose life is more important? These people are killing themselves. This person may be an innocent gunshot victim. And so there's reasons people have, even medical professionals have stigma. The education that we provide to first responders, we'll talk about that in a little bit, is to get police, healthcare folks to understand that these are human beings, with faults. We all have faults. I'm not perfect. I one time thought I was, but I'm not. Make mistakes. My mistakes may not be shooting heroin, right? But I know of civil cases where ER doctors and staff see somebody coming through the ER door and saying, that person's drug seeking.
Yeah.
They just want a script. And they come in, they complain of pain. That's a typical way to get an opioid from an ER. I got pain, doctor. And then all of a sudden, because of the internal stigma that needs to be dealt with, the ER doctor, the nurse, the staff there say, now turn around and get out. Well, it turns out they have an appendicitis, and it's burst. Right? You send that person out because you assume stigma causes assumptions. And when they're misidentified, hospitals lose millions. Doctors lose their license or get it, sort of checked at the door for a while. Stigma can be costly. It's not good. It's bad. Stigma characterizing a group of people and judging people in a harsh way is really what stigma is, and we all have to deal with it.
Yeah. So I guess this kind of goes into our next point of the stigma module, like how are first responders trained on stigma, how to reduce their own stigma so that they can effectively treat people.
So recognize that we all have stigma. We have to understand it. Just like bias. Listen, I'm not talking necessarily about like racial bias. Like that should be dealt with right away in someone's life. But some people grow up in a biased atmosphere in their family, so they have people have to address that. But sort of just judging people based on maybe some of their behaviors and not treating them well. Imagine if we have someone that can't stop drinking in a harmful way or using drugs and they're in our own families. That doesn't mean that we're not going to harm them with our bad stigma about it. And we could. In fact, we could get even more angry. Yeah. And so anyway, so with first responders, we teach stigma is really based on how we think, how we feel, how we speak. So the words we choose to use, right? So like the word junkie, that was a word that was thrown around for decades. But you see how demeaning that is. What is a junkie? A junkie is somebody that is living with substance use disorder. A better way to speak about it. And by the way, so I was undercover, so I had to street talk, right, to convince people that I wasn't a cop. I had long hair. I had a Fu Manchu. I dressed the part. If I was a high-level dealer, I had a nice silver suit, driving a red Datsun ZX T-top. I love that role, But if I was a user, I was, I had my garbage clothes on that and so. But anyway, so that stigma that we have, the words we choose to use. To think about people and then to speak and communicate with people, if they're poorly chosen words, we will not have positive impact. I don't care if it's my own children. I don't care if it's my friends' children that I'm talking to, students here at St. Joe's. If I throw that word junkie and other terms like addict, it's how you say it. If I use the word addict, and I often do, but I won't say it like, no good addict. I will talk about addiction. I use that term addiction It's better to use substance use disorder. It doesn't roll off the tongue for me really well.
Right.
But when I do use it in public presentations, the audiences enjoy hearing it from me because most cops don't talk like that. I didn't go to a drug dealer and say, "You sell me a bag of heroin because I have substance use disorder." Right? I definitely wouldn't have survived my career doing that. Right. But the other type of stigma that you can see on people is their expressions. So if one of you raised your hand and said, "Hey, I have a close family member with addiction, Steve. What can you teach me to help this person get into treatment?" And I look at you like, even I don't say anything, right? I'm communicating this internal bias I have and the stigma about addiction. You won't get that from me, right? You'll get, "How can I help you?" You'll get a very positive response. But a lot of people, particularly first responders that have to deal with this every day, doctors, nurses, PAs, all these folks that are dealing with this issue on the front lines, we just have to be very careful about our expressions and the words we choose to use. How's that?
That's great.
Yeah.
Do you think first responders generally now do a better job of that? Like both, and I guess in the hospital sense as well, just for the audience. Do you think that all the education efforts and stuff that are going into it are having a tangible effect?
I like to think that I'm winning this war.
Yeah.
Right? Just solo, me,
Right.
my associate director, and my beautiful team, at CARE. No, we're not winning the war, but we're getting there. We're addressing it. I don't point fingers at my audience of cops, for example. I don't point fingers and say, "You're doing everything wrong." You don't motivate anybody. And so you have to engage. Here's the critical point of influencing first responders, doctors, future doctors, to get them to lighten up a little bit and do things differently, is get buy-in. This opioid epidemic is affecting everybody, every race, every community. You could name a town in Pennsylvania and say, "Yeah, but they don't have, overdoses like they have in Philly." Well, yeah, but they have overdoses. They have addiction issues. Somebody's shooting heroin in rural towns. And so, the bottom line is you get buy-in from audiences because cops' kids, cops' cousins and uncles and brothers and sisters and spouses are all impacted by this. It could just be pills, but they know the impact. They know that their loved one can't stop popping pills. It could be Xanax or it could be an opioid, right? And so the buy-in's pretty easy if you're smart or gentle enough to not point fingers in the beginning. Buy-in, I think, with our audiences. We do a 4-hour training for most of our presentations. Buy-in can be gotten in 15 to 20 minutes when we talk about the impact on the family.
Yeah.
Yeah.
That's great. So I guess, how do you see things kind of progressing? One thing that we wrote a paper in the Institute of Clinical Bioethics about Adderall being laced with fentanyl and that kind of getting into college campuses, and kids who aren't saying, aren't driving themselves to Kensington to buy a bag of heroin are now being affected by fentanyl and overdosing and dying.
Yeah.
And,
So that's, listen, it's poison.
Yeah.
Right. What's out there in the market, the drug market today on the street, whether it looks like it's a real pill or not, if it's a bag of cocaine or methamphetamine, generally those drugs don't kill you right away, right? It takes time. It takes time. You could always overdose on heroin, particularly in the last 25 years. If you're used to 60% pure heroin, your dealer puts it up to 90%. May not be any fentanyl in it, but all of a sudden, boom, you have a bigger amount of opioid in your body, and then people overdose. Many didn't die right away, right? But yeah, the polluted drug supply is a real issue. I've had guns facing me. I got shot at. I've been in many violent incidents over the course of my career.
Wow.
Thank God I won all those battles. I don't get scared very much. But the very thing that you said, Joe, worries me. Even at a place like St. Joe's.
Yeah.
I'm a professor here as well. I teach alcohol, drugs, and society to undergrads. And sometimes as I put the syllabus together, every semester, tweak it a little bit. I don't want to put too much pressure on students because, and it's kind of silly, but too many reading assignments because somebody might take some Adderall, right, to try to stay up all night and try to pass the test, get alert. 25 years ago, 20 years ago, maybe even 5 years ago, the Adderall that students would, let's say, use to stay up, back in my day, it was called no-dose. It was really just caffeine. But if you can't find it through a legitimate source, like a pharmacy, you're going to go on the street. Or somebody's going to say, no, I got this from my script, and they bought it on the street. Yeah, the fact that the polluted drug supply has fentanyl in it is just, it scares me, honestly. It shouldn't. I face things, but it does scare me. And I want to get the word out. Even folks at St. Joe's, we just have to be careful.
Yeah.
Yeah.
Well, yeah, it is interesting and scary because a lot of kids, like something that we wrote about in the paper was that taking Adderall to stay up all night and study for an exam, like people after this started happening took a lot of data and put it all together and showed that like it really doesn't help. It doesn't make you smarter. It doesn't help anything. So it's really like kind of breaking down that misconception can do a lot to help.
I'm glad you guys look into things like that. That is probably the most worrisome thing that I have in the position that I'm in. One pill can kill is what DEA says, right? That's a campaign they have, is one pill can kill because of the fentanyl that's being laced into these products. And I don't usually like to be an alarmist. When I was your age, a little bit younger, in high school, they had somebody come into my school and say, if you smoke a joint, you could die. So those of us that were armchair researchers, we looked around at all our friends that were smoking joints. Nobody's dying. Like, they seemed to be pretty happy, right? So it was all BS. It was all like just this, this idea of trying to prevent somebody by lying to them. Unfortunately, it's not a lie nowadays.
Right.
It's 2023.
Yeah.
Yeah.
Sure.
Good? Everybody good? In the chat, throw us some questions. I mean, we have other things to talk about. By the way, it's really important that everybody get educated on Narcan. I have Narcan here. This naloxone is the product. Narcan is the brand. And Narcan, it comes in these 2-dose packets. These have 4 milligrams of naloxone in each of them. The newer ones are going to come out are 8 milligrams because the lethality of the drug, the opioids on the street, has increased. So you might have to give somebody more than 1 dose. But you'll learn all about Narcan. So I'm not going to teach it here. Yeah. But that's one of the things we teach all first responders, including people in the corrections field, right? Including children and youth services. In fact, on campus in my secret closet, I have $250,000 worth of Narcan that the Department of Health has asked me to get out to professionals like children and youth. Yeah. Cops have it. We've had it since 2017. Now children and youth wants it. And so we are not only giving children and youth caseworkers Narcan and teaching them how to use it, we're actually encouraging them to give it to their clients, the families that they're serving. If there's any hint that there's substance use issues in that family, and there's small children crawling around, maybe eating mom's pill or dad's pill they left on the counter, I want to make sure that those families that are struggling and hopefully getting some good help with children and youth, that they have Narcan in the home and know how to use it. So, but yeah, I'm really glad, Joe, that you guys are going to learn this and carry it. Have it with you. I took a long flight a couple of weeks ago to get away from it all, right? And I had Narcan in my possession on the plane, not my bag that I checked. I had it there in case somebody, God forbid, it's a long flight. It was like a 5-hour flight. And if there's somebody on there that's addicted to opioid pills or heroin, and that's a long time not to use. Yeah. And so I always want to have it with me. And I encourage you to replicate that in your own lives. Yeah. Please have it.
That's great. So, do you guys have any questions for now? Because we could just keep kind of I have a couple questions just about random stuff and all right.
So, talking about using extra doses of Narcan in your previous conversations about now fentanyl, including in the opioid discussion, do you think that drugs, particularly opioids, are just going to uh, be increasingly lethal as time goes on and we get better at producing more effective and more pure substances?
Yeah, that's a great question, great point. I can tell you up till now that has been the case. So heroin, you can live a long time. As long as you're careful, you can live a long time. And I learned this from various people, including the medical examiner for Washington, D.C. He had been around there for decades, and he told me once that the heroin users that were dying when fentanyl got introduced were heroin users for 30, 35 years. And occasionally they'd overdose, but they generally didn't die. And so, the fact that the lethality of heroin because of fentanyl in particular got thrown into this mix made it much more dangerous. So think about the business plan of cartels. So to kill off your own customers, right? Isn't that what's happening? So if there's, what's the estimate? I want to say 12 million Americans are using illicit drugs, right? And so you want to maintain that customer base. But what they did was, the cartel did, is they stepped it up. They added fentanyl to heroin because the addiction is much stronger. Very hard to get off of that, get into treatment, and to actually recover from it. It's possible, but it's just harder. So they want to have customers for life. They not only fentanyl, but there were 24 fentanyl-related substances in Pennsylvania. In all the testing that we did of the street drugs, like cart fentanyl, which is even more potent than just your average fentanyl. So it makes no business sense to kill your customers. So I don't know if the cartel is going to dial that back. I could tell you this. As of today, I heard from somebody that had some conversations with some drug trafficking organizations in the past week. They're really, in Mexico, they're cracking down on this tranquilizer, this xylazine product. That's also being added to the mix, right? The tranquilizer that, fentanyl has a very short half-life. You're going to want to use that much more than you would use heroin. And so what people do is what dealers do is they add tranquilizer xylazine into a bag of fentanyl, because it will then extend, you'll at least be tranquilized during the time that you're sort of withdrawing from fentanyl. And in Mexico, even among the cartels, they are doing their darndest to cut back or to stop the importation of xylazine into the Mexican market, because it's really polluting the substance, and it's causing, terrible wounds and all that stuff. So, but good question. I don't know that they're ever going to dial it back, and it's always a financial motive. You know what it takes to make heroin? It's the poppy plant, right? So you got to first of all have a field with the right climate, and you have to grow the poppy. And when the seed or the pod is at a certain maturity level, you have to have these farmers come out, laborers come out, and they score that poppy, right? And out drips opium. So they collect that. Then you have to take it and refine it into the heroin that Americans like. And you get high off of opium, but Americans want heroin, right? So you have the labor force, you have the lab that has to be, set up and run properly. Then you import, large quantities of it, kilo quantities across the border. Why not get a substance that's 100 or 1,000 times more powerful, so that when you bring it across the border, you can bring a smaller quantity, right? You're less likely to get caught.
Yeah.
And easier to conceal in compartments in cars. I've gotten it from car batteries, where they hollow out the car battery, and a working car battery. And I'll show you pictures sometime.
Yeah.
And but so I don't know. By the way, fentanyl is a lot cheaper to make. You don't have a labor force. You just mix a bunch of chemicals. Don't do this, but there's a recipe on the internet, and it's not a recipe from some tweaker lab. There's a recipe on how to make fentanyl from the U.S. government. That's where people learn. There's this, fentanyl, is a product used in the hospitals.
Yeah.
Well, there's actually, I found directions pretty easily and it's very harmless to make unless you inhale it. It's not like meth. You cook up a batch of meth, it could be an explosion. Fentanyl is very easy to mix up. And so no labor force, higher profit margins. That's why we have that. I don't think cartels are going to, be ethical,
Right.
and return back to the old school. So
Yeah. So something that I was told, I guess, in like some sort of education about opioids was that like the drug dealers that are selling, a supply that's making people overdose and die, that's attracting other users.
Yeah. So think about it. If I'm selling at Kip and Cambria down in Kensington, which by the way is a very high level market for heroin and fentanyl, even trank now, and they've been around 30 years. Like, trust me, I took a lot of action when I was in law enforcement, just in that particular street, that cross street. So yeah, they're very active in selling. I'm sorry, back to your question. Sometimes I go off track. But
What was my question?
Yeah,
Oh, yeah.
yeah.
Like why, like I said, I've been told that.
other
Why do
people get attracted.
Yeah, why do people get attracted if the supplier's selling something that's killing people?
Can we reduce
guess-
the stigma in the room? And I want us to imagine what it's like to be a user of heroin every single day. Let's just forget about our actual life. Go undercover with me. Imagine every waking moment, right? You are jonesing to figure out how to get enough money to buy heroin. And so it is the sole focus of you to make enough money. Let's say you don't have your bank account, so your mom and dad kicked you out, right? So you have no access to real money, so you have to really scam, steal, and do things you really can't imagine ever doing to get money. And you take your $10 to buy a couple bags from Kip and Cambria, and they sell you beat bags, fake heroin, which they wouldn't do at that market, but they do along Kensington Avenue. So Kip and Cambria, you buy, and it turns out you're really not satisfied. The product is not as strong as you're used to, and man, you spend all night getting $15, and now you got crap dope, right? So, where do you go to buy? Well, you start to hear on the street, you're ear hustling. You know what's going on, and somebody overdoses at Kip and Cambria. Where are you going to go? You're going to put your money somewhere else,
Right.
or you're going to go to the place that has the strongest drug, right? The strongest, most potent drug that just puts somebody down. And that's the mentality. Listen, don't judge people. That's survival. The brain is saying to survive, you need good quality dope, and go where it's obvious. That must be powerful.
Yeah.
And then believe you could do better. You'll shoot a half a bag. You'll test it out. Okay, it's bad. It's really lethal dope, but if I just use a little less, right? So you dip your toe in the water instead of shooting up, 3 bags at a time.
Yeah. So in that sense, do you think, the cartel is kind of preying on the nature of addiction for their own?
Let's
Obviously.
talk about doctors preying on the nature of addiction.
Right, yeah.
All right?
Yeah.
So let's talk about overprescribing doctors. I locked a bunch of them up over my time, and someday I'll teach you how I did it, but I'm not going to tell you now. It's a little secret. But I found out the top 1% of prescribers of opioids in Pennsylvania, about 50% were family doctors. Imagine that. Listen, anesthesiologists, they had a lot of fentanyl and pharmaceutical fentanyl, a lot of opioids, right? Doctors that were surgeons, that their practices, it makes sense, you know. But if you're a family doctor in rural PA, why are you like the top 1% of prescribers of opioids? You should be dealing with the flu, right? Strep
Yeah.
throat. You know, why do, and I used to look at the patients in their history and I'd say, this doctor is not only top 1%, but like 90% of the people that walk through that doctor's doors are getting prescribed Oxycontin. Like, what the
Yeah.
heck? Or a dentist, some of the dentists,
Right, yeah,
right?
yeah.
How bad of a dentist are you?
Yeah.
That 90% or 80% of your patients or 60% of your patients are getting a 30-day supply of Percocet. I mean, what are you doing with your dental instruments? You must be, really destroying the mouth. Instead of back in my day, you had saline and salt water. You just gurgle with it and maybe an aspirin or a Tylenol. Oh no, these dentists were out of control. So dentists or doctors can create customers for life.
Right.
And I've met them. I've interviewed them. I talk to them off the record, try to understand why didn't you order an X-ray or an MRI? Why didn't you order physical therapy? That helps. Torn muscles, strengthen the muscles around it, right? Oh no, Oxycontin, 30 milligrams, And so why did you do it? Why? Because I would, every month, they'd have to come back for a script. If they didn't have insurance, it's like $100, $150. Or if they did, I get the copay, and one doctor, family doctor in Satterton in Montgomery County, he took a trial and I testified. But when I was at his office doing a search warrant with the feds, we were grabbing patient charts and looking at things. There were people driving up, totally intoxicated, driving up, nearly running over us. There were FBI agents with FBI on their side, and they didn't even notice them because they were singularly focused. They get out of their cars with cash in their hands,
Wow.
right? And I'm like, I watch them. It was a little bit entertaining, I have to admit. But they walk up to the front door and I'd be like, whoa, 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 whoa. Don't you see what's going on here? You look around. No, I got to see the doctor. Right? That's addiction.
Yeah.
With cash in her hands for that office visit, right? And so this doctor's name was Dr. Ruth. You can look him up. Dr. Ruth, I want to say Richard Ruth Satterton. If you look up Dr. Ruth Satterton, he went to jail. He was 72 years old. He went to jail for 15 to 30 years. He's still there. I mean, that's a death sentence for him. Yeah. Every patient got Oxycontin.
Wow.
And I said, doctor, why? And he had all stupid excuses, but the reality was, you get somebody addicted to Oxycontin, to an opioid, they'll keep coming back.
Wow.
Terrible, right?
Yeah. We're getting a little bit short on time. Any questions here? About anything?
I have one question.
Yeah.
As someone in law enforcement, what are your thoughts on safe injection sites?
Great. I'm going to give you a very balanced view on this. First of all, I like the idea. These are human beings. I like the idea of it being a little bit safer, right, than shooting up in an alley. Yeah. Or, by the way, most people that overdose die at home unattended to. So there's a percentage between 50 and 60% of people die alone, right? Nobody helped, nobody with Narcan. You can't Narcan yourself if you're you can't breathe. Like that rarely happens, right? So I like the idea of safer consumption sites. It's not totally safe. You and I could shoot up fentanyl, maybe mixed with xylazine or anything, in an operating room and still die.
Yeah.
So you know that, right? It's not totally safe consumption sites. But I do like the idea because the greatest selling point to safe injection sites, which I want you to look at this whole issue. What's not being told is the most important part of it, is you're building trust. Building trust to do what? So that they can keep coming back and shooting up? No, build trust so you can motivationally engage people and let them start thinking about, don't tell them, let them start thinking about getting help, right? And getting help. And so safe injection sites, safer injection sites, what are use sites. I like the idea of building trust, just like syringe exchange. I like building trust to eventually help someone want to get help and then find help. What I do get concerned about is the neighbors. And I could spend a lot of time with every one of you and explain what it's like to live in North Philadelphia, Kensington, Southwest Philly, where you see a lot of drug use. You know, mom and dad, they tell you can't wear flip-flops out of the house. You're going to get stuck with a syringe. Or walking around people to go to school from 5 years of age, right? You don't want that. So the consumption sites, they have to think about where. They have to make sure the dealers stay away. You know, so police have to be involved to keep the dealers. If this class, we were one drug organization led by Joe Kelly, and we were sort of new to the area, where would you set up business? If there was a Kip and Cambria, if there was a safe consumption site, I'd try to get there because that's where the people are. You know, so police have to keep the dealers away. Does that make sense? Like give it some deep thought. Talk to the people that it's going to impact the public. You're not going to convince everybody it's the right thing, but done the right way, I'm a huge supporter of it. You know, this is a medical issue.
Absolutely.
I'm also a supporter of law and order, and here's why. You'll find this, I think you'll find this to be true if you really research it. If there is no consequence to shooting up heroin, xylazine, fentanyl, smoking crack, whatever it is, if there's no consequence to that, right, which there isn't in, let's say, Kensington, open air market, police officers are taught, do not arrest, right? For all of those 800 to 900 people, they count them every month, that are unhoused and using on the sidewalk, shooting up in each other's necks. Yeah. If there's no consequence, like a temporary, like an arrest, maybe a temporary stay in jail, if there's no consequence, even the greatest harm reduction folks have told me, I had one in the studio today, Sarah Laurel from Savage Sisters. Look up Savage Sisters. She was right here in the studio today. And she said, Steve, they have to have consequences. She said, I found a pathway to treatment in jail. And she said, there's no, and she's a big supporter of safe consumption sites. But she's like, Steve, the fact that Philly police don't even arrest you, you know, and I said, Sarah, I'm surprised you're saying that. She said, there's no ramification of this behavior. And she said, I myself learned that I should really make some changes because I was sitting in jail cells. Does that answer your question?
Yeah, that was perfect.
All right.
Thank you.
Your namesake was here, Sarah Laurel. Look her up, Savage Sisters, Philadelphia. Oh, God, she's just a beautiful human being.
Yeah, we're trying to do something with them as well.
Oh, good.
Probably the next semester. This is
Yeah.
a full year thing, but we unfortunately, it does look like we're out of time. I know you have to run. So thank you guys all for your engagement and your good questions. And yeah.
Hey, thank you. Reach out to me anytime you want. Steve Forzato. We're gonna get a film together of this available.
Yeah.
We'll get it out to all of you. You can share it with your families and friends and colleagues if it's helpful. But you can always email me, either using my name, you know, Steve Forzato at St. Joe's, or CARE, C-A-R-E, care at sju.edu. That gets right to me. If you want to talk more, if I can ever help you think through this, I'd be happy to. You mean a lot to me. You're future healthcare providers. Together we could beat this problem, right?
Absolutely.
Thanks, Joe.
Thank you. Thanks, guys.
Thank you very much.
Yeah.
Thanks.
Thank you.
You bet.
Thank you.